All right, hello everyone. My name is Andrew Niekamp. I'm a member of the SIR-RFS Research Committee. We're here tonight to do a journal club. We're going to be discussing a polymer-coated paclitaxel-eluting stent, ELUVIA, versus a polymer-free paclitaxel-coated stent, the Silver PTX, for endovascular femoral popliteal intervention. This is the IMPERIAL trial. It was a randomized non-inferiority trial. And what we're going to do basically tonight is we're going to go step-by-step through the trial. Dr. Vatakencherry from Kaiser LA is going to be moderating the session. He's going to be jumping in periodically, giving us clinical pearls, asking questions to a panelist of us that are going to be kind of fielding the questions, answering them, and trying to keep the whole conversation really focused on what's the clinical importance of this study and how can it really help us take care of our patients. If anybody throughout the course of the webinar has any questions, please put your questions in the question box to the right. You'll see it under your dashboard, and we'll be keeping an eye on that as we go through. If there's any good questions that come up that we feel need to be answered, we'll ask them to the panelists. So we'll go ahead and get started here. So the purpose of this study was to compare the safety and efficacy of a novel paclitaxel-eluting durable polymer-coated ELUVIA stent. This is made by Boston Scientific. And this was basically, this was to compare it against the established Silver PTX stent, which was produced by Cook. The primary efficacy endpoint of this trial was primary vessel patency at 12 months. The way that they defined primary vessel patency was a binary endpoint that was based on duplex ultrasound of a peak systolic velocity ratio of 2.4 or lower at the 12-month follow-up visit as assessed by ultrasound in the Vascular laboratory. And this had to be in the absence of clinically driven target lesion revascularization, or TLR, or bypass of the target lesion. The primary safety endpoint was basically occurrence of major adverse events. And these major adverse events were defined as all causes of death through 1 month, major amputation of the target limb through 12 months, or TLR through 12 months. Clinical outcomes were distribution of Rutherford category, which we'll touch on later, primary sustained clinical improvement. This was also assessed through the Rutherford categorization, hemodynamic improvement by ABIs, and then also walking function.
So let me ask you, the panel, a quick question. So since we did talk about Rutherford, I don't know if you're going to go into more detail. I think you are. But yes. Just kind of like, how do you guys break down, peripheral arterial disease, and what is the use of the Rutherford classification to help you do that?
So I can take this. So Rutherford classification, you have just for the panel, or just for the audience, you have two types. You have Rutherford for acute limb, and you have Rutherford for chronic limb. The one that's in question for this study is chronic limb. You have essentially 6 different categories ranging from 0 to 6, 0 being asymptomatic, and then 6 being major tissue loss, and then everything in between. So I believe the 1 to 3 are for claudication, mild, moderate, severe. 4 is rest pain, which is where you start getting into the whole critical limb ischemia category. 5 is minor tissue loss, and 6 is the most severe, which is major tissue loss.
Excellent. So I think it's very important that you utilize something like the Rutherford classification when you're dealing with chronic limb ischemia. Now, let me ask the panel another question. What's the significance of 0 through 3, meaning asymptomatic to severe claudication? What's the risk of them losing your leg? Because if you have arterial blockage, it's just like a heart blockage. You worry about a heart dysfunction and left ventricular dysfunction arrhythmias. What about the leg? If you have blockages and you have either mild, moderate, severe claudication, what's your risk of an amputation in 5 years?
I could try to answer that. So the key thing being, up to for 3, you have claudicants, and the natural history for claudicants, they actually have more than mortality related to cardiovascular events, and the risk of amputation or leg loss is less than 5% at 5 years. So I think that's something key to recognize of claudicants.
Very good. I think what's always helped me was to categorize claudication as non-limb threatening, while critical limb ischemia is limb threatening. So I think that always sort of helps me kind of remember the risk of limb loss for both of those.
So that's an important thing. Anytime you're looking at a trial, and this is, it's a randomized control trial here, you always want to look at the study population that's being studied. And as Andy Niekamp is going to showcase, well, what that population is, versus a claudicant versus, a critical limb ischemia, which is Rutherford 4 through 6, with 5 and 6 being, basically tissue loss. So what is the risk of losing a leg in a critical limb ischemic patient, i.e. Rutherford 4 through 6, in a year?
Yeah, you're gonna have rates of almost up to 25%.
Excellent. So that's an important factor. Now you're dramatically increasing your risk of limb loss, and those are patients who need something done more urgently. Whereas the claudicants, they're not going to lose their leg. They're going to be bothered. It's a bothersome symptom, but not a limb salvage situation. So just understand that anytime you're looking at a trial, that this Rutherford classification is an important parameter to understand. If you're dealing with peripheral arterial disease patients, it's important to guide and counsel them about their natural history, because a lot of even primary care docs may think, oh, they're going to lose their leg. And a lot of patients, that's going to be their primary concern when they come to your office. So it's important that you kind of relay their fears and educate them about the natural history of the disease. All right, keep on going, Andy.
Absolutely. No, thank you. That was great. So going back to the trial, there were secondary endpoints that they also had at 12 months. And these secondary endpoints were, one, technical success. And this was obviously defined as deployment of the assigned stent to the target lesion to achieve residual angiographic stenosis of less than or equal to 30% when this was assessed visually. Procedural success, and then adverse events, stent integrity, obviously, and then clinical events committee had adjudicated events that did not meet the definition for a major adverse events, which, again, just to remind everybody, that was any death, target lesion revascularization, target limb amputation, or stent thrombosis. So let's do a little background here. Let's talk about what in the world is the difference between the ELUVIA stent and this established Zilver PTX. So Zilver, which is the established Cook stent that we have 5-year data on, this is a polymer-free, it's a self-expanding slotted tube. It's a nitinol stent. And again, this is polymer-free paclitaxel coating that has 3 micrograms per millimeter squared of the stent material. The ELUVIA stent is actually coated with a polymer. And this polymer has an active layer, which is composed of a matrix, and this paclitaxel is embedded within this matrix at a dose density of 0.167 micrograms per millimeter squared of the stent surface. So as you can see, Zilver's 3 micrograms per millimeter squared compared to ELUVIA, which is 0.167 micrograms. So it seems like ELUVIA might have a lot lower dosage. But when you look at the trial, actually, ELUVIA has a much longer sustained paclitaxel dose within the serum measured at 1 year. Zilver is almost undetectable. So Zilver has much more of a peak paclitaxel during the immediate post-procedural time period, while ELUVIA has a steady elution of paclitaxel. Even up to 1 year, they were actually finding levels of paclitaxel within the patient's serum. And that's what we kind of talk about here.
So let's bring up a mechanistic approach. Why would this is a chemotherapy drug, right? Why
Yes.
would that be a benefit in the vascular bed, Taxol, basically? Like, how would it work? Like, what is it doing to prevent problems down the line? We know it works in the coronaries for drug-eluting stents. We've seen the benefits in drug-coated balloons. It's a new standard, but why? Why is it working? Anyone?
Yeah, so I mean, basically, we're just looking to, prevent neointimal hyperplasia,
Right.
and that's the biggest thing that we need to try to avoid, because that's, usually one of the biggest reasons of in-stent restenosis.
Exactly. So your body's got a foreign body, either an injury by a balloon dilation of the intima, or a metal piece foreign body in there, and your body responds to that foreign body, even though you're opening and cracking the plaque, by developing scar tissue. It's like you're generating a scab. Well, this is an antimitotic agent that you're administering to prevent that scar tissue from forming. So that's basically what we're doing. And this is the bane of what we do in the vascular bed. And anytime we put in a stent or balloon dilate or do anything, it's a scar tissue or that intimal hyperplasia. And so if anyone can identify the way to basically eradicate that, you'll win a Nobel Prize.
Yeah, bane of existence. And we're also going to touch on a little bit more about neointimal hyperplasia as we get later on in the presentation. So, but I'm really glad you brought that up, Dr. V. That's it's really important to understand why are we using paclitaxel, and that's the real reason why these drug-eluting stents came into existence. So let's so back to the study. So how was the study? What did they do? So it was a prospective randomized control style study. This was global. They had 65 community hospitals spread throughout Austria, Belgium, Canada, Germany, Japan, New Zealand, and USA. And patients were enrolled beginning in December of 2015 all the way through February of 2017. The inclusion criteria, the patients had to be 18 years or older. They had to have symptomatic lower limb ischemia. And again, this goes back to our Rutherford categorization, which we talked about earlier. They had to be Rutherford category 2, 3, or 4. Like we said, these are claudicants. These are not CLI patients, so that's very important to remember. They had to have stenotic or restenotic, meaning that they were treated with a drug-coated balloon greater than 12 months before the study, or standard percutaneous transluminal angioplasty, or POVA. Or they had occlusive lesions in the native SFA or the proximal popliteal artery with at least one infrapopliteal vessel that was patent to the ankle or the foot. Patients also had to have stenosis of 70% or more on visual angiographic assessment, and the vessel diameter had to be between 4 and 6 millimeters. And the total lesion length that they included in their primary study population was between 30 millimeters and 140 millimeters. Important to note is that there was a separate cohort that they did have of lesions of greater than 140. That paper is actually being published separately and will be coming out soon. But as far as the actual IMPERIAL trial, of which we have results of, the lesion lengths were between 30 to 140 millimeters. Okay, so this is just a breakdown. This is an overview to show how the patients were basically broken down. So started out with about 152, 328 of which were eligible. They were assigned at a 2-to-1 ratio of ELUVIA to Zilver because this was a non-inferiority study. So that was the division that they came up with in order to obtain enough power of the study to make sure that they could prove non-inferiority. Eventually, it came to about 294 were in the full cohort analysis for ELUVIA, and about 146 were assigned to Zilver. Again, like I just said, patients were randomly assigned 2-to-1 implantation of either the ELUVIA or the Zilver stent after the treating physician had successfully crossed the target lesion. So the physician was able to get across, and then that's when randomization occurred. The patients were the ones that remained matched to the treatment that they were assigned and received until all the patients had completed their follow-up visit at 12 months. These clinical follow-up visits were scheduled at 1, 6, and 12 months after the procedure. The follow-up is planned to go through 5 years. This is really important because the data that we have for Zilver goes to 5 years. So ELUVIA wants to carry out, Boston Scientific wants to carry out this study through 5 years to see how it does stand up to Zilver in the long run. And these clinical visits will be at 24 months and 5 years. There'll be a clinical or a telephone follow-up at 3 and 4 years. Okay, so this is also a really important topic, something that I think we're going to talk about here for a little bit. So anticoagulation. So what were these patients put on afterwards? So anticoagulation, antiplatelet therapy were administered during the procedure, and they were consistent with what they considered current clinical practice. What does that mean? That means at a minimum, these patients had to be on Plavix 75 milligrams or ticlodipine started at least 24 hours before the procedure, or a peri-procedural loading dose of 300 milligrams of Plavix or ticlodipine of 200 milligrams. They were then carried on dual antiplatelet therapy. This was required for the first 60 days after the procedure. This was in accordance of previous trials of both devices. ELUVIA had already been through a first-in-humans trial, and that was what they're referring to here when they said previous trials of both devices. And then antiplatelet monotherapy was then required throughout the 12 months of follow-up. And again, they recommend antiplatelet monotherapy through completion of the trial in 5 years.
So let me ask you, panel, like, what is the rationale, especially in the coronaries? We know that drug-eluting stents, we have to put them on dual antiplatelets for 6 months a year, and then we have to be very cognizant that we can't stop it because else it'll occlude. Why is that? Whereas bare stents, you have a little bit more leniency in the coronary bed. What is the rationale for that? I think these drug-eluting stents are better, so why do we have to put them on more aggressive antiplatelet?
Yeah, I can try to answer this. So my understanding is that the drug-eluting stents prevents, as we talked about, the neointimal hyperplasia, which is actually protective against platelet aggregation. So the fact that you have a drug-eluting stent is preventing neointimal hyperplasia, which is protective, obviously, of platelet aggregation. So the fact that you have that stent in place is going to you're going to lose that protective measure of the platelet aggregation. So in fact, you're going to promote it. So these stents, the drug-eluting stents, are more likely to have platelet aggregation, aka thrombosis, within the stent.
Yeah, it's this unfortunate catch. It's this just unfortunate catch-22. You know, you're preventing neointimal hyperplasia, which causes stenosis, but by losing that neointimal hyperplasia, there's more endothelium that's exposed and damaged, and so therefore you need to keep these patients on dual antiplatelet therapy for longer to prevent that from happening. So it is this weird catch-22. That was perfectly put.
Yeah, no, great.
All right. So, Dr. V, you all good to move on?
Yeah, no, it's perfect. Yeah.
Okay. All right, great. So, materials and methods. So this is a breakdown of the patient distribution. We really wanted to highlight a couple things here. First of all, this study had 34% females in the ELUVIA trial and 33% in the Zilver trial. That's huge. Women are frequently very underrepresented in these trials. Dr. Coe from UCSF actually gave a talk at Viva this couple weeks ago, actually investigating why women are so underrepresented in these PAD trials. So it was really important to see that women were actually very well represented, made up almost a third or over a third of the patient population. Also, like 40% of these patients were diabetics, which we know are going to have more severe symptoms and more severe disease with PAD. Calcification was found, in a large amount, which is also a very important aspect of lesion characterization, and then percent diameter stenosis is also really important. So these are really big patient demographics that you should look at when you're trying to evaluate a study to kind of figure out, how well representative is this, and how sick are these patients, and how strong of a study is this. And we felt that these characteristics were actually very well represented in the trial.
Yeah, no, I think that's a good point. So the way I break it down is two kind of key factors: patient demographics and then lesion morphology. And as Andy discussed, historically there hasn't been a good observation of what happens in the female patient population with vascular disease, but I think this study is at least making a move in the right direction. Second is diabetes is a big confounder that you have to be aware of. And so that's another thing to really kind of focus on. And then panel, I want to ask you, what are the kind of lesion morphologic characters? I know you talked about calcification, and I know you talked about degree of stenosis or occlusion. Anything else that's important in the PD subset?
Yeah, I think one of the things which Andy kind of talked about was the lesion length. This study is looking from 30 to 140 millimeters, and the longer lesions, traditionally, like you're kind of referring to the TASC classifications, tend to be historically less favorable endo and more of a surgical kind of approach, although, that's being shifted right now with newer technology and scales. But I think the length of the lesion is something to look at.
Great. So that's an important thing that when we're looking at any clinical trial is not only the demographics, who's with the Rutherford classification, are they diabetic, et cetera, but also lesion morphology. Is it heavily calcified lesions or not? Are they occlusions or stenoses? Are they long segments? So, i.e., is it a claudican or CLI patient? Is it multi-level disease? If the disease is a short segment SFA, or is the entire superficial femoral artery, which is around 30 centimeters versus 3 centimeters. So this is kind of a short intermediate length disease. Good.
Okay. Awesome. Okay. So here were the results. And as you can see, the statistically significant result. And keep in mind that this trial was designed to be a non-inferiority trial, meaning that they needed to just prove that the ELUVIA stent was non-inferior to Zilver. What they actually found was that the primary patency of ELUVIA at 1 year, 12 months, was 86.8% compared to 77.5% for Zilver. And this was found to be statistically significant. So in the IMPERIAL trial, they found that not only was the stent non-inferior, it was actually superior to the Zilver stent. The rest of these things you can see here, very important, any death, target vascular or target lesion revascularization, target limb amputation, all of these were very similar between the two groups, and none of them were statistically significant, meaning that both of these stents actually performed very well when it comes to any of the secondary outcomes. They also performed very well and equally when it came to major adverse events, but it was the primary patency that was found to be statistically significant, and that's what really made this an important trial, was that ELUVIA was actually found to be superior to Zilver in their analysis. So this is a really important slide. So what we have here on the first two bars, these are the baseline Rutherford categories. And as we talked about, you can see a majority of these are actually Rutherford 3, with a slightly lesser majority being Rutherford 2, and then a small amount of patients in Rutherford 4. As you can see, at 1 month, 6 months, and 12 months, we see a vast improvement in Rutherford categorization. Well over 60% of all of these patients went to a Rutherford 0, with a bigger proportion then being Rutherford 1, a small amount of patients then being Rutherford 2. So we see some statistically significant and dramatic improvement in Rutherford categorization post-stent placement at 1, 6, and 12 months in both the ELUVIA and the Zilver PTX stent. So we've kind of talked on this right now, but I wanted to show everybody a slide here that really goes over what the Rutherford classification is. So we started 0, obviously, from asymptomatic. There's no hemodynamically significant occlusive disease. These patients have normal treadmill. They have normal reactive hyperemia. And it goes all the way through, as you can see, as you increase in the Rutherford categorization, you get more and more severe until you get all the way up to 6, which includes major tissue loss extending above the tarsal level. And the functional foot is no longer salvageable. And these objective criteria are the same as 5, which is some severe peripheral vascular disease, with tissue loss being most prominent and the defining clinical description in 5 and 6. Once you hit Rutherford 4, this is when you're starting to get into CLI, and this is when you have ischemic rest pain. So, Dr. B, I didn't know if you wanted to take over and jump in.
Yeah, no, I think you said it quite well. This is probably one of the more important slides from an understanding of the natural history of this disease. 0 through 3, as Andy said, different beast than 4 through 6, where 0 to 3, the risk of limb loss is exceedingly low at less than 5%. So any intervention you do, you always have to weigh a couple of things. What are the risks of the procedure, or what are the benefits of your procedure, and what are the alternatives? And so let me bring that question up. What are your alternatives, and how effective are they for claudication?
Are you talking about improving claudicant symptoms?
Sure, correct.
Okay, so we know that exercising regimens have been proven to improve walking distance. We know that cilostazol is also a big agent that has been proven to improve walking distance as well. And then definitely statins. Getting them on high-intensity statins is going to be very important. These can all help improve claudication symptoms other than, intervention.
Good. So yeah, those are 3 medications, or 3 interventions that you can provide when you're seeing the patient in the office. So cilostazol, 50 to 100 milligrams BID. Be careful in CHF. Exercise, write them a prescription. That's what I do, and I bring them back and have them bring their log and ask them to walk till it hurts about 7 or 10, and then keep on coming back until 30 minutes, and I ask them to walk, tell me how far they walked and how long before they start to develop the pain, and over a month and 3 months and 6 months. And same with statins. Not only does it reduce heart attacks and strokes, but also improves walking distance. So how long does it take for cilostazol, which is improves walking distance by 50%, or exercise to take before you see kind of some of the peak effects? 1 month, 6 months, 3 months? Roughly how much time do you have to tell the patient to wait?
About 6 months.
Yeah, very good. So you have to tell the patients, unfortunately, to be patient, but it does take some time for you to see the benefits of these treatment algorithms. But it's important in a patient who's not likely to have risk of limb loss. Now, in all these patients, 0 through 6, like someone was saying, that there's a risk of cardiovascular and cerebrovascular events and high mortality related to that. What are the other adjunctive therapies, not from a limb function, but from a mortality standpoint, that you can give these patients? And you mentioned statins, and clearly this is a population that should be in high-intensity statin therapy with perhaps LDL goals of less than 70. What other things can we add to the amalgam potentially to reduce mortality?
So I think the way I simplify it is to think about the four major measures that we want to improve. So obviously statins will improve the lipid panel in our favor, and then we want to also improve the blood pressure and glucose. So ACE inhibitors would, I think there's a couple trials that have shown that ACE inhibitors are the blood pressure reduction with ACE inhibitors can reduce cardiovascular events. Statins, obviously, as we have already mentioned, as well as pretty intense glucose control. And then obviously a lot of these patients are smokers. So if they are smoking, then we want to make sure that they we promote smoking cessation.
Yeah, so pretty good. So basically, statins for sure, right? They will reduce cardiovascular cerebrovascular events. Again, goal-directed therapy of less than 70 probably in this population. ACE inhibitors, based on the HOPE trial, independent of blood pressure reduction, actually shows an event reduction, right, in the PAD subset. So I think it's important that you realize that independent of blood pressure reduction, there's some benefits of this agent. And then smoking cessation is another key player. So statins, ACE inhibitors, smoking cessation, possibly antiplatelet therapy. And if I were to pick an antiplatelet to prevent events, which one would you advocate and why?
So I think like in the within the PAD population, you if possible try to lean towards Plavix based on the results from the Capri trial, which is kind of a stroke trial, but showed some benefit within the PAD subpopulation.
Good. So yeah, you can consider Plavix in this high risk population versus baby aspirin or so. But yeah, and what about dual antiplatelet? You haven't intervened on them, but would you consider dual antiplatelet in this population rather than just Plavix alone?
No, I think the Charisma trial, I think, was the one that can show clinical benefit.
Yeah, so you got to be careful because there's always a risk of bleeding, right, for any of these interventions. And we've seen most recently multiple randomized trials looking at the aspirin for primary prevention being kind of negative, not having benefit, but having some increased bleeding potential. So always recognize that there's always risk and benefit even with these drugs. We think they're not completely benign. So dual antiplatelet without intervention, not necessarily benefit in the PAD population based on Charisma data. Perhaps Plavix may be better than aspirin, but certainly an ACE inhibitor and a high-intensity statin and certainly smoking cessation approach are things that we can all do. Good. And then diabetic control is really to prevent the opathies, right? Nephropathy, neuropathy, retinopathy. So certainly we want to get their A1Cs less than 7% as far as goal-directed therapy, and certainly something we should really strongly encourage and look at their microalbumin, make sure not that having nephrotic range proteinuria or proteinuria of any significance that we can reduce by putting them on meds. So when we're seeing these patients, we're also trying to manage these other conditions to reduce the mortality and morbidity associated with these diseases. Good.
Okay, great, awesome, great discussion. And so I also wanted to show, like we were just talking about, Dr. B was talking about the importance of lesion morphology. This is a common classification system, the TAS2 classification system that's used for SFA and basically femoral popliteal arterial disease. So this is just a really important slide that I think all trainees and everybody should become familiar with to really understand lesion morphology, because it's going to be a language that is spoken quite widely. And it really helps at least get some sort of a classification down to understand these lesions. All right, so going back to the trial, this was the big results slide. This is what really came out after it. Here we see here that ELUVIA was shown to have primary patency of 88.5% at the 390-day follow-up, with Zilver PTX of 79.5% at the 390-day follow-up. This was shown to be statistically significant and put ELUVIA above as superior primary patency at 390 days. They also did they did a proportion of patients that went without TLR or target lesion revascularization. This also showed that ELUVIA was slightly higher than Zilver PTX at 95.4% compared to 91.9%. However, this was not statistically significant. So both stents showed significant prevention of target lesion revascularization, which was really important. So the conclusion of the trial, they found that their paclitaxel-eluting polymer-coated stent was non-inferior to the paclitaxel-coated polymer-free stent. This means that ELUVIA was non-inferior to Zilver PTX in maintaining primary patency at 12 months, and they had a similar safety profile. And they said, based on these results, the use of the polymer-coated or the ELUVIA stent in patients who require SFA or popliteal intervention is a reasonable approach to maximize intermediate-term patency and to maintain hemodynamic and clinical improvement without repeat reintervention. Basically, their conclusions were that the stent was non-inferior and was actually shown to be superior to the Zilver PTX. All right, so let's break it down. Let's kind of dissect this. Let's talk about this study and really throw out any critiques that we could possibly find. This is really important when evaluating any sort of a study. You really need to look at it, dissect it, kind of ask yourself, you know, were there any issues with the design? Was there a flawed design? Were there things that were left out? Was the patient population adequate? Was it powered adequately? From all those standpoints, this was a very well-designed trial. It was very well powered. Patient demographics were very similar. The lesion characteristics were overall similar. They was powered adequately. It was a very well-designed study. The number one discussion point is that the primary non-inferiority endpoints at 12 months were met, and the post-hoc analysis of the 12-month patency rates showed superiority for ELUVIA. Again, something that we all need to know, though, is that there is 5-year data that is available for Zilver. We do not yet have 5-year data for ELUVIA. So this IMPERIAL ELUVIA trial is going to go to 5 years. We'll just have to wait, obviously, another 4 before we get that data, and that's going to be really important because then we'll be able to compare, you know, a little bit more directly what the 5-year data is between Zilver and ELUVIA. It did show that the proportion of patients with stent thrombosis or clinically driven TLR in the ELUVIA stent were about half those in the Zilver PTX group. This was a proportion again. This was not found to be statistically significant, but it was something that was important. It is important to understand that although there was primary patency that was better in the ELUVIA, both groups did show significant improvements in clinical symptoms and walking function, and the occurrence of stent fracture was extremely low. So all of the secondary outcomes and endpoints, and as well as the major safety endpoints, were very similar between the two stents. Something that was also interesting, which came up actually in Viva that I learned was, and this was actually mentioned in their study very briefly. It's in one of their discussion paragraphs. It kind of gets glossed over, but there was concern that the ELUVIA stent can actually cause some sort of aneurysmal degeneration within the wall. Now, granted, this was found to be a very, very low percentage of patients. I think only 6 patients had this, but they did not have transverse ultrasound images, which is the best way to diagnose aneurysmal degeneration. These were not available for all patients. So basically, this needs to be something that is followed up. Does the ELUVIA stent cause some aneurysmal wall degeneration? Again, very low number of patients this was found in, but it was found, something that needs to be followed in the future. And lastly, CMS reimbursements is a huge issue here. For those of you that don't know, drug-eluting technology such as drug-coated balloons, DCBs, and drug-eluting stents, DCBs actually, after December, CMS reimbursements for a DCB will be the same as POBA. No longer will they be reimbursing the drug-coated technology. So if you use a plain old balloon, it's going to be the same as a drug-coated balloon after December. For drug-eluting stents, the reimbursement is a little bit better, but because ELUVIA is a new stent, there is going to be novelty to it, and so they have a proprietary that's going to be more expensive. Something that if you run an OBL, you're really going to have to consider because these are more expensive stents. Yes, it does show superior in primary patency, so you are going to have to evaluate if that's the stent that you want to use. It does have improved primary patency. Do you want to use that compared to the Zilver PTX? So you know, finances is something that's going to come in with these stents, and it's very important to keep that in mind. Also, to just keep an eye on CMS. It is very important to know what is being reimbursed, what is not being reimbursed. Are they being reimbursed at different rates? So this is also something that's very important. Not sure if the panel wants to jump in with anything that they had. Okay. I thought another interesting thing actually with this too is the Zilver PTX is a polymer-free stent. This is basically what they call the Generation 3 stents. In the coronaries, a polymer-coated stent, which is the ELUVIA stent, these are actually no longer used in the coronaries because there was evidence of distal thrombosis of these polymers. They would break off and embolize distally within the coronary system. So basically, that was the first generation drug-eluting stent was polymer-coated stents. They've moved away from them because of this distal embolization that was seen in the coronaries. So it's interesting that the ELUVIA went back to a generation 1 stent and is now polymer-coated in the periphery. Could these polymers cause distal embolization phenomenon? It's unclear. We didn't really obviously see any in the 12-month follow-up, but it is something that needs to be followed because it is a fundamental difference between the two stents. We know that they're not polymer coated, are no longer used in the coronary, so we'll have to see if they actually do cause any trouble in the periphery. Panelists, any other closing thoughts or comments?
Yeah. So one of the things I noticed, you mentioned it briefly, but the fact that the cutoff for their sizes for how long the lesion has to be was very short, relatively speaking. I think their cutoff was like 14 centimeters, I believe, 1.14, or was that 14 millimeters, 1.4 centimeters.
No, 14 centimeters. You're right.
14 centimeters. I apologize. 14 centimeters. The SFA is 30 centimeters, I believe, right? Something along the lines of 30 centimeters. So pretty routinely, I think we see the SFAs, the whole length being stented. So I don't know, Dr. V, you have any thoughts on that? If that's something that is of noteworthy significance?
Yeah, I mean, I think it's important anytime you look at the trial to assess that, because your real world experience is that you're going after these log segment calcified CTOs, either subintimal or luminal. Will that data translate? Probably not, but they, like you said, I think Andy said they're doing a long lesion subset analysis, and there's also the data from the Silver Path, which looks pretty promising, at least the 1-year data, comparing that to above knee PTFE. So we're looking at maybe some paradigm shifts in how we look at long segment SFA lesions based on the Silver Path data. So I think there is some reasonable data coming out for looking at long segment SFA disease, whether using covered stent graft technology or even the drug-eluting stent technology as seen by Silver Path. But you're right, when we're looking at this specific study, not apples and oranges. So we're looking at a claudican population. We're looking at 3 to 14 centimeter lesion length, and we're looking at kind of what that patency is for that population. And I can't say a 30 centimeter stent's going to have that patency.
So we actually have some good questions from the audience. If you guys want to field these, I'll go ahead and propose these. So one of the questions that was brought up is, can we talk about why cilostazol is mechanistically contraindicated in CHF?
Yeah, that's a really good question. So basically, there's been some kind of issues with milneuron, which is a phosphodiesterase inhibitor in the congestive heart failure patient population with the potential increased mortality. So based on the mechanism of action, that is the theory, the rationale for kind of holding off on cilostazol, basically an EF of less than 45%. That's kind of where I go. But it's based on some kind of adjunctive similar phosphodiesterase inhibitors and their reactions.
Gotcha. Dr. V, a quick follow-up question to that. If we have a patient, let's say we have a patient that we're about to start Pletal on, cilostazol on, and they do not have an echo on record, should we order an echo, or should we just kind of go off the clinical symptoms? And if they are obviously
really good question. The funny thing is, I used to kind of based on the clinical signs and symptoms, how far they can walk, etc. Can they lie flat? Do they have any crackles, any JVD, etc. And a lot of patients will have an echo sometimes. But then one of my patients actually, he looked and saw the FDA black box label when I prescribed it for him, and he had no kind of symptoms. But so I went and ordered an echo. It's almost like ordering a radiograph these days. So now I don't. It's not a barrier to me. I'll order the echo before I started.
So there is another question here. Excuse my pronunciation because I've never heard of this, but in my studies, I've come across a drug called pentoxifylline in discussion with cilostazol. Are there any evidence for the use of this drug in PAD? Not sure if any of you guys are familiar with this, if anybody is aware.
So that's pentoxifylline was a theoretically a rheolytic agent. It's supposed to change the morphology of the red blood cell. Now, years ago, that's what a lot of people put patients on. Trentolizid's kind of brand name. But, it's never been proven to work. When compared to placebo, it's no better in a randomized fashion. So, most people have fallen out of favor of that based on the randomized trials and the whatnot. So it's not proven efficacy in the subset, in the population.
Awesome. Okay. So
I have a question kind of for the panel. Kind of knowing what we know now with this 1 year data, how do you implement it in your clinical practice? Like say a patient, has an 11 centimeter SFA lesion. What do you do?
Oh, and let me ask you this, more importantly, what if this is your granddad or grandmother and they have like Karthik said, they're claudicating and they have an 11 centimeter lesion. They're really bothered by it and they want to know what would you recommend? And there's no right or wrong answer. I'm just curious to see what the panel would do based on this data.
So my thoughts on this were that this is something that we brought up. There's a metric that we were using. There was a number that we were using, which is the ratio of the peak velocity in the stent versus in the native vessel adjacent to it. And it was a 2.4. That was the number, 2.4. So if you were to use that number, which is essentially a measure of the in-stent thrombosis, then ELUVIA wins, and there's a lesser degree of in-stent thrombosis in ELUVIA.
So,
however,
my question is, right now, today, in 2018, in November, what are you going to tell your granddad?
Right. So my lead up to that is that I would stick with Zilver for a couple of reasons. In that the clinical symptoms didn't change. The metric that they used, the ratio that I just mentioned, there was a statistically significant difference, but clinically these patients did the same on both stents. So ELUVIA is more expensive, but the clinical symptoms were the same as Zilver. So if it was my patient, if it was my granddad, I would still go with Zilver.
And if I may just add to that, I mean, I definitely agree with this. And I think there is one point that we should not really forget in terms of the results of the study is that at this point, they still lack long-term outcomes. Yep. So even though they're showing a good result at this point, we don't know what the long-term is going to be. It's very possible that the trend might reverse for some reason or another. So I would treat this data very cautiously myself.
And I think that's a good point in anything we do in interventional, okay? Is safety. There's three things that I look at when I'm looking at comparative data, all right? Safety, efficacy, and durability, all right? So is it a safe procedure? In short, you have 30-day, safety, and then maybe short-term, like 1 to 2 years, and intermediate in the 5-year range, and then long-term, 10, 15, 20 years, something like that, right? That's safety, the safe. Is it efficacious during that period? And is it a durable technology? Is it going to occlude? And that's why there's stent fractures. Is this metal implant going to fatigue or cause a problem? So we need to, just like, we've seen that with filters where they fatigue, they fracture and whatnot. So we can't just assume, short-term, safety and efficacy, because is it a durable product or is it going to get into trouble later? And so anytime you're looking at any interventional technique, you always have to look at that, whether it be ablation, whether it be embolization, whether it be ICD, pacer, stent graft, abdominal and thoracic stent grafts, TAVR, is the durability as well as the safety and efficacy, short, intermediate, and long term.
There's another question on here. Is positive remodeling more common and or more pronounced with polymer-coated stents? I saw a brief presentation of this at Viva, but I'm not sure if anybody else knows the answer to this.
I do not.
No idea.
Yeah, so now I have to give full disclosure here. This was at a Cook presentation, but they actually did have cross-sectional pathology slides of the neointimal hyperplasia that occurred following Zilver versus ELUVIA. And Zilver did have less areas of unorganized fibrosis than ELUVIA. So it actually looked like, it depends on how you're kind of, I guess, defining positive remodeling, but overall it seemed like Zilver did have more of an organized, smaller neointimal hyperplasia with less areas of fibrosis and disorganization than ELUVIA. Again, disclosure, this was at a Cook presentation, and I didn't really get to dive in and evaluate it that much myself, but that's what I've seen thus far.
Yeah, so I mean, I would take, who knows what, we have now randomized control trial data comparing two different devices, core lab adjudicated. So it's a good study and it's a comparative trial. So who knows what it really means? Does it mean anything clinically? We'll find out. And I think it seems like, and Andy, you can correct me if I'm wrong, but this study is going to continue for 5 years. So hopefully we'll get some, longer term, intermediate and longer term data, which will be pretty exciting.
Absolutely.
And so one of the things that I think is very exciting is that we've been in the realm of drug-coated balloon versus plain old balloon angioplasty, stent versus plain old balloon angioplasty, in a randomized fashion. Finally, we're getting that data. And then now we're looking at two different drug-eluting stents and comparing them head-to-head. And that's a paradigm shift in the peripheral bed. We finally have got to that point. Maybe we'll see one drug-coated balloon versus another drug-coated balloon. So we're seeing incremental benefits potentially of different stent technologies or stent polymers, et cetera, which I think is exciting and in a randomized fashion, looking at different types of endpoints. So when you're developing and designing a trial that's meaningful to a patient, how would you define the primary outcome goal that you would want to achieve, say in this claudican population, and then we'll talk about a CLI patient. In a claudican population, if you were to design a primary endpoint, what would it look like, panel?
Really great question. I mean, I don't personally, if you're asking me what's most, I mean, it sounds like you're kind of asking what do you view as most important? And for me, it's what the clinical symptoms of the patient, like what is actually happening to their life? Are they saving their limb? Are they improving with their symptoms? Like, is it, like you said earlier, is it safe? And does it really fix the patient's problem?
Good. Because in the end of the day, that's what the patient's going to want to know, right? Like, they're coming to your office with a problem. You don't want to make them leave your hospital in a worse situation than they came to. That's, prima non nocere. So that's most important. And so you need to figure out, first of all, what's going on, how bothersome is it, in some type of metric scale, walking questionnaire, something. How functional are they? Is it, and also realize in this older population, there's multifactorial issues, right? The majority of patients don't have classic claudication, right? The majority of patients have atypical leg pain. They'll have like some hip pain, some knee arthritis. They'll have some spinal stenosis and neurogenic claudication. They may, venous claudication, et cetera. So oftentimes it's the multiple things that you have to tease out what's really bothering them the most and how bothered are they by it. Some people are not bothered at all, by the symptoms. They're not at risk of limb loss per se. So you have to use that in the situation. Is it limiting their lifestyle in the sense that they like, I can't live like this, is an important thing. Yeah. So yeah, I think clinical, analysis is always important. Like, are the patients happier after this? Did you prevent events?
Yeah. Actually, you have a really good question that I've actually, I would love to hear your guys' thoughts on this. So with studies like this requiring an understanding of lesion characteristics, can we expect a falling out of the classification systems like Rutherford and Wi-Fi in favor of TASC?
Yeah, so I think that's a great question. So I do think that each of these will have some importance. I think, so it depends on what you're treating, right? You're treating claudicant or you're treating critical limb ischemia. So when we're looking at critical limb ischemics, there's three factors that are important. So I would query the panel, what are the three factors that are important in a critical limb ischemic patient who's coming into the ER with a problem, with a wound?
Are you asking for what are the clinical symptoms or what are the physical exam findings?
No. So you got a patient with critical limb who's coming in. The ER is telling you, hey, this patient's got a wound. Kind of, and that you want to characterize how significant is this wound. What are the three things that you should think about?
I think one of them has to be the wound itself, whether or not it's infected.
So one is it infected? How bad is infection? How bad is the wound, meaning how large and necrotic or how extensive it is, right? And how is the supply, the circulation to that bed, right? So those are the three things that I would characterize when you're looking at a wound. The Wi-Fi kind of uses some of that component. TASC gives you kind of a bit of lesion morphology, meaning how likely are you to have success from an endovascular approach, or in dealing with this improving the circulation. So you want to at least optimize the circulation. You need a controlled infection, and then you got to figure out how to manage the wound and how can you resolve it with a minor amputation and maintain mobility of the patient, i.e., can you get away with a TMA, maybe a Chopard's time, something of that nature? How, what can you, or toe amputation or something, or ray amputation, what can you do to preserve that patient's functional status, right? Or you're going to have to go to BKA or an AKA again. These are all things that we're trying to address for this patient. We want to keep them functional, right? So how bad is the wound, how bad is the infection, and what is the circulation? And the circulation is kind of the task. The Wi-Fi kind of gives you some of these kind of overlapping things. There's different ways to kind of stratify it, but those are the three things I look at. And Rutherford kind of just gives you a guide to is it asymptomatic claudicant or critical limb ischemia, and how bad is the critical limb ischemia. But really, if you're dealing with wounds and gangrene, again, those three things are important. Is it infected? Is it dry or wet gangrene? And is it infected? How bad is it? Can you control that infection? Is the wound really, really massive where you're not going to get recovery? And is the circulation such that you can improve the circulation to a point that you can get wound healing? And we have gotten so much better as an interventional community improving the vascular circulation to optimize the chance of healing. But healing is not just opening up the circulation. You got to control the infection. You got to make sure the diabetes is under reasonable control. You got to make sure they have adequate nutrition. You have to make sure you have a very aggressive wound care team and podiatry and other surgeons to kind of assist in really getting this, under control.
Yeah. Okay. Well, we are actually nearing the top of the hour. Are there any other closing remarks? Any other closing questions that the panelist has? We still have a couple more minutes here. Okay. Well, that's it. Oh, sorry. Okay. All right. Well, I sincerely want to thank all of our attendees today. It's been great having all of you here. I really hope you guys found this beneficial. Just a little PSA. We do plan on having numerous of these. We're going to go back and really evaluate a bunch of landmark articles. They can be new, groundbreaking articles. We're actually going to look at some, older articles that may shape how we clinically practice right now. We plan to have these very frequently as we go forward. So we hope if you found this beneficial, if you found this educational, come back, join us for our future journal clubs. Also, spread the word. We'd love to have more people and really make this more of an interactive session and really give people as much educational experience as possible. I'd like to sincerely thank our panelists, Shantanu, Warhapande, Vatakencherry, and Dania Daye, have all been really great contributors. And I really, really want to thank Dr. Vatakencherry from Kaiser LA for leading the discussions and really giving us the clinical edge and the clinical acumen to make this trial really impactful for all of us. So we'll go ahead and close it out here and just thank you all very much again. We look forward to seeing you next time.
Thanks, everyone.
Awesome. Thanks for having me.
Thank you all.
Good night, everyone.